I believe that the future of gastroenterology becomes to the young generations. And so we designed these sessions to see how powerful of the new generations. We get the first speaker for Professor Ang, please.
The first speaker is Dr. Noor Purdah binti Abdul Kadir. She's from Malaysia. She's a fellow in neurogastroenterology and motility disorder at the Hospital University Science Malaysia. And today she's going to share about the results of a survey concerning gut dysbiosis in Malaysia. Dr. Abdul Kadir, please.
Okay, Assalamualaikum and a very good morning. Thank you for the introduction. My pleasure to be part of the meeting today. And gladly, I would like to share our study on a survey of awareness and perception of factor influencing gut microbiota in early life, disease associated with gut dysbiosis in early life, and usual practice on the use of probiotic among physicians and parents in Malaysia. Although there is rapid progress in diagnostic and therapeutic area of gut microbiota, the awareness among public and physicians in Malaysia is largely unknown. Therefore, we conduct this study to determine level of awareness and perception of clinical practitioners and public, specifically parents in Malaysia. So here are how we conduct our study. So in terms of the questionnaire development, the questionnaire was developed by the gut allergy expert panel consisting of pediatrician, immunologists, allergists, GI physician and scientists with special interest in this area, and it was validated among a group of doctors and parents. Content validity score was 74% and 62% each. The questionnaire contained 3 sections. Section A basically on demographic detail of respondent. The section B on awareness of factor influencing gut microbiota in early life. This section contains 7 items. And then section C on awareness of disease associated with gut dysbiosis in early life and the usual practice on the use of probiotic in this disease. This section had 10 items. So all responses were on Likert scale. 1 indicate strongly agree and 5 indicate strongly disagree. Participants were given an invitation link with consent to the validated questionnaire. The data were reported using mean standard deviation and the differences analyzed using an independent t-test. So here are the results. The questionnaire had been completed by 819 participants with the mean age of 36.17. And then 51.9% were female participants and the remaining 48.1% were male gender. And then when we look at the group, for 53.5% from the healthcare practitioner groups and then 46.5% from the parents group. So we move into the section B on the level of awareness and perception and factor influencing gut microbiota in early life. This table showed that the mean score of each item for this section for the healthcare professional group and parents group. The highlighted item were the domain with significant difference mean score of healthcare professional and parents group. So the correlation level of awareness and perception and factor influencing gut microbiota in early life among clinical practitioners and parents in Malaysia showed significant difference in score with p-value less than 0.01. We can see here in healthcare professional group, the mean score, total mean score was more higher compared to the parents group with the reading 3.13. And then we move to the section C on the level of awareness and perception of disease associated with gut dysbiosis and their practice on the use of probiotic. This table also showed the 10 items in this section. It showed that each mean score for each item for the healthcare professional and parents group. The highlighted item were the domain with significant different mean score of healthcare professional and parents group. And then when we look specifically at the item C4 on the question of practice on the use of probiotic, This item showed significant differences in mean score in between parents and healthcare professional group. But the highest mean score we can see in the parents group with the mean 2.92 compared to the healthcare professional group 2.48. So meanwhile, for the level of awareness of the disease associated with gut dysbiosis and the usual practice of probiotics showed significant difference with p-value 0.013. But we can see the total mean score in the parents group is a little bit higher compared to the healthcare professional group with the reading 3.12. So in conclusion, the level of awareness toward factor influencing gut microbiota, disease associated with gut dysbiosis and the usual practice of probiotics are inadequate. Overall mean score we can see here is just above average. Healthcare practitioner did better with factor influencing gut microbiota in early life, but parents did better with practice of using probiotic. So awareness campaign are recommended to increase knowledge to improve gut health among Malaysians. With that, thank you.
Thank you so much for your talk. And right now, as we open for the Q&A session. Maybe start first with the questions. Dr. Kadir, would you please let us know about the clinical applications of your studies? What is the main clinical application?
So the clinical application for our study. So basically we see that overall awareness is actually the mean score is at average. So in the real clinical practice, maybe we should come up with the more campaign and awareness for the clinical practitioner and parents in terms of this microbiota knowledge.
Do you have any questions from the audience? Okay, thank you so much, Dr. Kadir. And before we send up your talks, Professor Ang will give you a certification for good memory and as a Rising Star. Next, we're going to move to the second talk from Dr. Natsuda Aumpan from Thailand. Dr. Natsuda, currently she is the junior faculty at the GI unit, Thammasat University. Her research interest is about the microbiota and fecal microbiota transplantations. Her talk going to touch on the efficacy of encapsulated FMT and the FMT via rectal enema for the IBS patients. This is a DBRCT trial. Professor Aumpan, please.
Thank you for your kind introduction. I am Dr. Natsuda from Thammasat University. Today I'm going to touch on the topic of efficacy of encapsulated fecal microbiota transplantation and FMT via rectal enema for irritable bowel syndrome. This is a double-blind randomized placebo-controlled study. I have nothing to disclose. IBS is a common functional bowel disorder. Dysbiosis potentially contributes to the pathogenesis of IBS. FMT is an administration of fecal solution from a healthy donor into intestinal tract of a recipient. FMT could be a possible treatment option to restore normal gut microbiota in IBS patients. FMT provided benefits in patients with IBS in some previous studies. However, most previous studies used colonoscopy or other invasive techniques. This study aimed to compare efficacy of encapsulated FMT with rectal enema and placebo in IBS patients. The study design is double-blind, randomized placebo-controlled study. We included Thai patients aged from 18 to 70 years old with IBS diagnosed by DOM 4 criteria at Thammasat University Hospital between April 2021 and November 2022. We used donor screening protocol for FMT. Our stool bank was established in 2019 for the centralized facility for donor screening. All our stool donors provide informed consent and have to pass both clinical assessment and laboratory screening. Our stool bank is certified by Biosafety Level 2. Donor stool was kept in a deep freezer. When using for FMT rectal enema, it was stored to room temperature and mixed with 200 cc of saline. Then we remove fecal material and debris. For the encapsulated FMT, stool was processed by lyophilization at minus 50 degrees Celsius and filling into 24 capsules. We prepared donor stool or placebo enema and capsules in our stool lab. Then we administer FMT or placebo to a patient by rectal enema by completely covered syringes and FMT of placebo capsules. We excluded patients such as pregnant women, severe comorbidity. Then patients were randomized into 3 groups. The first group is FMT rectal enema. Patients will receive FMT rectal enema and placebo capsules. The second group is encapsulated FMT. Patient receive FMT capsule and placebo rectal enema, and the placebo group received both placebo rectal enema and placebo capsules. We evaluated vital stool scale, IBS symptom severity score, and quality of life at 2 and 4 weeks, and also adverse events after FMT. Our primary objective was to evaluate IBS-SSS at 4 weeks after receiving FMT capsule, FMT rectal enema, or placebo. Secondary objectives were to evaluate quality of life score, adverse events, and change of gut microbiota before and after FMT. All data were analyzed by SPSS version 22. We obtained all written informed consent from patients. From table 1, we observed that no difference in baseline characteristic among 3 groups. And from table 2, there was a significant improvement in IBS-SSS at 2 and 4 weeks. Overall response at 2 and 4 weeks. Abdominal pain and abdominal distension at 2 and 4 weeks, and quality of life at 4 weeks in the FMT capsule and FMT enema than the placebo group. And from figure demonstrated IBS-SSS quality of life and abdominal pain score was significantly better in the FMT group than the placebo. Only minor adverse events were reported in all groups and no serious adverse event was observed. Fecal microbiota analysis demonstrated significantly higher alpha diversity after FMT. We found that Ruminococcus tox, Doria species, Bifidobacterium longum significantly increased after FMT, while Faecalibacterium prausnitzii decreased after FMT. This is a pioneer DBRCT on encapsulated FMT and FMT rectal enema for IBS patients in ASEAN. Prior studies demonstrated improvement of IBS symptoms after FMT by invasive procedures. Our study provided significant improvement of IBS symptoms by using less invasive FMT technique. Mr. Chairman, ladies and gentlemen, for my summary, encapsulated FMT and FMT rectal enema is a highly effective and simple way to perform without serious adverse events in IBS patients. increased microbial diversity after FMT might be correlated with favorable outcomes in IBS patients. FMT is a microbiota-based medicine which has true clinical potential and personalized approach with several therapeutic outcomes for IBS treatment in the near future. Thank you for your kind attention.
I think we are open for Q&A. Anyone like to ask any questions? If not, can I ask a question? For the two arms with capsule and also enema, do the patients need to take a bowel prep before that to change the?
Thank you for your question. We do not do the bowel preparation before the FMT rectal enema.
Okay, thank you very much.
So before we go to the next speaker, I'd like to invite Professor Ang to give a certificate, just like a great memory for the rising gastroenterologist. Thank you so much, Dr. Natsuda. And we're going to move to the third speakers.
The third speaker is Dr. Saif Ullah. He's from Pakistan and is currently a PhD fellow at the first affiliated hospital at Zhengzhou University, China. Today he's going to talk to us about endoscopic retrograde appendicitis therapy, novel therapy. All yours.
Thank you so much. First of all, I would like to thank organizing committee for the kind invitation. Okay, today I'm going to talk about endoscopic retrograde appendicitis therapy. I am sure most of you are going to hear this for the first time. So actually, acute appendicitis is most common surgical emergency, and for more than a century, appendectomy has remained the first line. Nowadays, laparoscopic appendectomy is the most common wherever the resources and expertise are available. Although appendectomy is like the standard, however, it carries the risk like many other open surgeries, such as post-operative ileus pain, as well as the risk of wound-related complication. Furthermore, there remain a risk of negative appendectomy as well. And you see, after the appendectomy, there is always remains a scar, as you see, like after open surgery, and this is laparoscopic surgery. And as a gastroenterologist, we always perform the colonoscopy, and during the colonoscopy, we find like the appendiceal orifice. Always, these are the figures from the colonoscopy. We can see the very clear appendiceal orifice. So actually, the patient problem is not the appendix, but the appendicitis. What is the cause? So the most common causes of the appendicitis are fecal, lymphoid hyperplasia, foreign bodies, or food debris within the appendiceal orifice. So here comes the concept of IRAT. This is my professor, and he's my supervisor during master's and now PhD. First time he introduced the IRAT to the world. So inspired by the clinical use of endoscopic retrograde cholangiopancreatography, ERCP, to treat acute suppurative cholangitis, Professor Liu Pingrong developed a minimal invasive technique known as IRAT for treating acute uncomplicated appendicitis. So first case was performed in 2009, and first time it was presented at DDW USA, and first work was published in 2012. Okay, basic procedure of the IRAT, how it does work, how does it work? Cannulation, it's the same like we do for the ERCP, cannulation of the appendiceal orifice, appendicography. We will go one by one. First of all, appendiceal intubation. Like it's very simple. We use a transparent cap at the tip of the endoscope, and then we do the appendiceal intubation. It is the same as we perform for ERCP. And the second step is appendicography, as we do the procedure in ERCP settings. So cholangiography, we can see under cholangiography. And the third step is appendiceal stone or fecal extraction and appendiceal lumen irrigation. So if there is any pus or whatever, we can irrigate it, or if there is any stones, we can use balloon extractor or in a basket to extract it. And at the end, we can deploy a stent. We can place a stent, depends on whether there is a stricture or not. So this we draw technical description of IRAT. So you can see here, first find the opening of the appendix, then appendiceal intubation, appendicography and irrigation. A basket or balloon is used to extract the fecals or whatever the debris inside it. At the end, irrigation and stent placement. And these are the live picture from the endoscopy. And find the orifice, and then you can see in the second B picture, in the B figure, you can see there is a pus coming out, right? And then you can see the stricture. We place the stent, and after the stent placement, the lumen is cleared. Okay, there is a video I would like to show you how we perform the IRAT. First of all, find the opening of the appendix. It is the same like when we do the colonoscopy. And then appendiceal intubation. As I told you, it's the same as for ERCP. And then when we decompress, you see the pus is coming out. This is the pus itself is coming out after insertion. When you do the decompression and the pus comes out. That's why we say like the patient problem is not the appendix. So we should not remove the appendix. And then after filling defect can be seen on appendicography after we clear the appendix. Actually, this procedure is very beautiful. You see now the appendix is clear after injecting the contrast. Okay, if there is a fecal or any debris inside it, we can also remove it using the balloon or basket. You see how inside it. It's like very easy thing. If as a gastroenterologist, we always perform the colonoscopy, and you don't have to train yourself so much for this procedure. Just like if you can perform basic ERCP, you can do IRAT as well. At the end, we place the stent because there was cases of recurrence. Then we start placing the stent, and the recurrence rate has reduced now. So we recently published a paper in Endoscopy Journal, is one of the leading journal in endoscopy. We compared the endoscopic retrograde appendicitis therapy with laparoscopic appendectomy. This was a propensity matched initial analysis. And we can see like in the beginning, the IRAT success rate was not high. It's 92% because some of the patients failed to cannulate. And overall, like adverse event was less, hospital stay was shorter, and procedure time was less. What is the indications of IRAT? At current, we are only performing IRAT in those patients suspected to have acute appendicitis without evidence of appendiceal perforation or radiographic suspicion of appendiceal tumor, and who may have appendiceal wall thickening, periappendiceal edema, and or associated fluid collection are considered candidate for IRAT. But very recently, we are also performing IRAT in periappendiceal abscess patients. So far, we have performed more than 20 cases. So, and this is the first clinical trial we published in Journal of Digestive Disease. And this is comparing IRAT with the appendectomy. This is the first clinical trial on IRAT available, and the results were very favorable for the IRAT. And we also compared and published a study in British Journal of Surgery comparing the endoscopic IRAT with antibiotics, and the results were very favorable for IRAT. As there is a very recurrence rate with antibiotics, maybe around studies considering 30 to 39%, but with IRAT it's only 8%. With antibiotics, the recurrence rate is very high. And Then some piece of opinion, we published this surgical perspective. This is published in Annals of Surgery. Endoscopic retrograde appendicitis therapy, is it really a need of the hour? In the beginning, surgeons were not agreeing on this, and they were not publishing the work on IRAT, but now most of the surgery journals are publishing work on it, and surgeons also learning endoscopy and trying to do this procedure because they know we will take their work if they don't do this. So at the end, conclusion, IRAT has surfaced as a variable alternative to surgical appendectomy and is rapidly being adopted as an option for the initial therapy or potentially for examining the appendix after successful antibiotics therapy in select part of the globe. When most of this procedure is being performed in China, so far we have performed more than 10,000 cases. IRAT is not only an effective treatment modality for acute and complicated appendicitis, but it also has a value in obtaining the etiological diagnosis of appendicitis. Wherever available, IRAT has the potential advantages of outpatient management. Now even we perform the IRAT in outpatient settings. Patients come, and if patients choose not to want to do the procedure without anesthesia, we can finish this procedure in 20 to 25 minutes and patient can walk back home the same day. Whether this technique can be widely adopted across the globe, particularly in the Western world, as an alternative to appendectomy remains to be seen. Etiology-specific treatment algorithm for IRAT are established for cholangitis are needed. It behooves surgeons and gastroenterologists to become proficient in cannulation of the appendix and dealing with appendiceal obstruction at extra. There is also a need for multinational collaborations and a consensus on training and conditioning pathway for IRAT and on areas of future research necessary to widespread adoption of IRAT. Thank you for your attention. If you have any questions.
Thank you so much for your intellectual talk, and they have questions from the audience. Professor Mahashai, please.
Just a couple of questions.
Yes.
So this is only done in China?
Yeah, so far, but recently some of the procedures done in Europe, very few, recently published in endoscopy, but mainly done in China.
I see. And are there any report complication like perforation or sepsis infection with this technique, and how long you leave the stent in before you remove it or just let it pass?
Okay, so the complication with this technique so far we have only feel like there is only recurrence rate. There is no other complication we observed so far. There is a recurrence rate around 8 to 10%. And about the stent displacement, usually we re-examine the patient after 2 weeks. In most of the patients, the stent dislodges itself. We don't need to do anything. If it doesn't dislodge, then we have to do colonoscopy to remove it. 2 to 4 weeks, depending on the patient condition and the strictures.
And this is done by the surgeon or GI endoscopists?
No, gastroenterologists are doing, but now we are training surgeons to do so as well, because if we are doing this and we are taking all the patients from the surgeons, it's not good. So we told them, we train you, you do by yourself as well.
Okay, which one is quicker to do?
And of course, we are good, and gastroenterologists good with the colonoscope.
I mean, compared to other surgical technique like laparoscopy.
This is quicker. This takes almost same time as required for the colonoscopy. Colonoscopy we usually take 10 to 12 minutes, but it's around 20 to 25 minutes and maybe 30 minutes.
To save cost, eh?
Yes, save, and this procedure can be done without anesthesia. It's up to the patient. We offer him with anesthesia or without anesthesia. It can be done without anesthesia. And the patient, there is an immediate pain relief. If we remove the cause obstruction, patients can walk home right after the procedure. Immediate pain relief.
Can they get recurrent problem in the future? Can they get recurrent appendicitis?
Yes, there is around 8 to 10% cases. In the beginning, we didn't place the stent, so there was a high recurrence when we did the clinical trial. But now we are performing another study, multicenter study, and we are keeping the stent in the patients. Yes, because the main cause is obstruction. If we keep the stent, so it may resolve the problem of recurrence. So if the recurrence is resolved, I think this technique have a good future.
Will you start doing in Pakistan?
Of course, we are going to do from February. Professor Amber is going to open there.
Thank you.
Okay.
Just for quick questions, I think time sequence is going to be very important for treatment of the acute appendicitis. So how long you have to wait for the acute appendicitis going to start? Maybe just only for 1 to 2 days, right? That you can do the IRAT.
You mean it's an emergency?
Yes.
So,
yes.
Okay, I got your question. So it depends. If the patient is not in emergency, the symptoms are mild or moderate, albedo score is less than 6 or something, then what we do, we admit the patient and perform the routine bowel preparation, which takes 6 to 8 hours, and we can do the procedure next day. But if the patient is in emergency, we perform the enema and a bowel preparation, which takes 3 to 4 times each 30 minutes. So it takes 1 to 2 hours, and we can perform the procedure in emergency. But recently, Lancet published a paper. They said we do not need to perform emergency surgery for appendicitis. So maybe it will give more space to Iraq for the bowel preparations.
Okay, thank you so much. And finally, Professor Ang, will you please to give a certificate for memory of the Professor Ullah? Next, we're going to move to the next talks. The next talk's going to for Professor Kenneth Lin. Professor Lin has his medical degree from Monash University, Melbourne, Australia in 2014 and complete his specialty training in gastroenterology and hepatology in 2021. Now, Dr. Lin is a currently associate consultant and advanced endoscopy fellow at the Changi General Hospital. Dr. Lin, please.
Thank you, Prof. Thank you, Prof, for the kind introduction. Good morning, everyone. My name is Kenneth. I'm one of the gastroenterologists from Changi General Hospital. It gives me great pleasure today to share with you on a hot topic, artificial intelligence in colonoscopy. Before I continue, I would like to thank the organizers for the kind invitation, as well as to congratulate everyone here, as well as the committee for a wonderful and successful event so far. So without further ado, I'd like to share this topic. So, introduction. Colorectal cancer is the leading cause of cancer-related morbidity and mortality worldwide. As we all know that colonoscopy is the gold standard to detect and remove colonic polyps. However, even though the adenoma detection rate, in short ADR, is an established quality indicator, it is subjected to high miss rates of up to 25%. Hence, the clinical solution actually involves two aspects. The first is to use mucosal exposure mechanisms such as AI-assisted colonoscopy, dye spray, or the use of other sort of virtual chromoendoscopy mechanisms to enhance the mucosa detection. The second aspect is actually to make use of device-assisted colonoscopy devices such as endocuff in order to expose the mucosal folds and to improve the inspection of the mucosa. The other aspect of the colonoscopy is actually to look for improved clinical quality indicators. This table is actually adapted from Prof. Douglas Reck's commentary letter, where he actually put up there the best clinical indicator, the best quality indicator right at the top, all the way to the one that is actually not the best at the bottom. As we can all see here that the adenoma detection rate is fairly low down. So currently, the role of AI improving ADR is actually very well established based on the various studies and meta-analysis that have been performed. However, there are clinical limitations. Firstly, we do know that quite a number of polyps can actually be hidden behind the folds. And if these polyps are actually not within the line of sight of the AI system, it will be missed. Secondly, as mentioned earlier, ADR may, even though it's actually the quality indicator that's widely recognized right now, it may not be the best quality indicator. And whether or not there's actually a role to use other quality indicators such as adenoma per colonoscopy. The two questions that I'll be answering today will be, number one, does incorporating AI in colonoscopy improve adenoma per colonoscopy, in short APC? And does the addition of colonoscopy-assisted devices such as endocuff on top of AI-assisted colonoscopy improve APC? I've actually looked into the literature and found these studies that looked at the impact of AI-assisted colonoscopy on APC with the mean and standard deviation as shown over here. In total, there are actually 12 studies that actually looked at the impact of AI-assisted colonoscopy on APC. But do take note that most of these studies actually do not look at APC as a primary hypothesis and a primary objective. A lot of all these studies actually looked at APC as part of their secondary analysis. Nevertheless, it is actually important to note that most of these studies showed that AI-assisted colonoscopy is better than standard colonoscopy in terms of the improvement of APC. Now, what's the next question is, what's the impact of AI-assisted colonoscopy on the APC when we perform subgroup analysis based on the size of the polyps? This meta-analysis performed just a couple of months ago actually showed that AI-assisted colonoscopy performs better as compared to standard colonoscopy in terms of the detection of diminutive polyps that are around 6 to 9 mm in length, as well as polyps that are more than 10 mm. The next question, does the addition of colonoscopy-assisted devices such as endocuff on top of AI-assisted colonoscopy improve APC? There are 2 studies so far that have been performed combining the use of AI colonoscopy with endocuff versus the individual devices. And these 2 studies actually showed positive results on the use of the combination of AI-assisted colonoscopy with endocuff in terms of improving the APC as compared to their individual devices. From my knowledge, there are a few other studies that have been performed around the world, and most of them are actually completed, and we are still waiting for their results to be published. The last aspect that I would like to touch on is AI colonoscopy cost-effective? This study was actually performed recently and published recently in the United States, and they look at the microsimulation of a hypothetical cohort of 100,000 patients in US. They actually wanted to elucidate the impact of AI-assisted colonoscopy versus one without on the cost of treating the colorectal cancer. As we can all see here that the AI-assisted colonoscopy actually resulted in a reduction in the incidence of colorectal cancer, and this actually, as a result, translates to a mortality reduction. This table here shows the cost involved in the treatment of colorectal cancer if detected by AI-assisted colonoscopy versus standard colonoscopy, as well as the cost involved during the surveillance programs. The first box in red actually shows that the treatment that is related to the treatment of the colorectal cancer, if the colorectal cancer were to be detected by AI, is actually much lower as compared to if standard colonoscopy were to be involved. While doing surveillance programs, AI colonoscopy may cost a little bit more as compared to one without the use of AI because of the additional implementation of the AI system. The overall incremental cost for the use of AI-assisted colonoscopy is actually lower by $57 US per patient. And as a result, there's actually a potential use of AI-assisted colonoscopy in terms of cost reduction and cost effectiveness. With that, I bring all of you to my conclusion. With regards to the beneficial role of AI-assisted colonoscopy during our clinical practice, it is also potentially cost-effective. However, it depends on the region, the local institution, as well as the resource allocation that is available. But more studies are actually required to evaluate the impact of AI on other quality indicators, such as post-colonoscopy colorectal cancer rates. With that, I thank you for your time, and these are my references.
Dr. Lin, thank you for your excellent talk. We open for a Q&A sessions. Have any questions from the floor? Maybe I start the questions for you. I believe that the times to do the colonoscopies may be one of the important factors, and comparing with the normal colonoscopy and when you use with the AIs, they have a difference of durations for the procedure.
Sorry, Prof. You mean
for durations of the colonoscopy procedure with or without AI?
For the duration?
Yeah.
So duration, I suppose, is actually going to be the same. The only sort of like time that is actually needed is just to switch on the AI system. So while we actually depend on the AI system to help us detect these lesions, it is also important that the endoscopists actually took on the responsibility to detect these lesions as well. It is also, as a result, very important to keep the withdrawal time, because if you were to withdraw it too fast, the AI system, I believe, will not be able to detect as well. So keeping up to the quality indicator and time withdrawal is actually of utmost importance if you want to, I feel, make use of the best of both worlds.
For the price of the colonoscopy with AI, you mentioned is around 470 something.
Yes, it's approximately slightly less than $100 more if you were to implement the AI system.
Okay.
Yeah, but the overall cost in terms of cost effectiveness in terms of the colorectal cancer is actually lower for AI-assisted colonoscopy.
It's only in Changi General Hospital or around Singapore?
Yeah, we are using it, yeah.
Okay, thank you so much for your excellent talk. And then before we go to the next speakers, let Professor Ang's gonna have a certificate for Dr. Lin.
So I'm pleased to introduce our fifth speaker. He's Dr. Titong Sugihartono from Indonesia. He's currently a lecturer in internal medicine at the Faculty of Medicine at Airlangga University, Dr. Sutomo General Hospital. And today he's going to talk about how cytokines can actually affect the development of erosive esophagitis and also symptom perception.
Thank you. Good evening, everyone. I got the sentiment of gratitude in this forum. And my name is Titong. I'm a gastroenterologist from Indonesia. And now I want to share with you 1 hour study with the title, The Role of IL-8, TNF-alpha, and IL-17 in the erosive esophagitis development and symptom perception in GERD. Okay. This is cross-sectional study with conducted in 2 hospitals, Dr. Sutomo General Hospital Surabaya and Siti Khadijah Hospital Sidoarjo. We recruited adult patients with heartburn and or regurgitation at least 2 times per week for at least 3 months. And all subjects will undergo endoscopy examination and distal wanted biopsy sampling. In addition, we exclude subjects with history of autoimmune disease, cirrhosis, malignancy, pregnant women, and other pathology upon each the exception erosive gastritis and Barrett's esophagus. Okay. The Los Angeles classification system was used to determine the severity of esophageal mucosal erosion. And in this study, we define subject with LA grade B, C, and D as the erosive esophagitis group, and subject with normal endoscopy feature and LA grade A as the non-erosive groups. And to assess symptom perception, we used to validate the Indonesian version of questionnaire, the GERD-Q, and the FSSG. The ELISA method was used to measure serum level of IL-8, TNF-alpha, and IL-17, and the cytokine level were compared between the erosive and non-erosive group. And after statistical analysis, we additioned to evaluating the correlation with the total score from GERD-Q and FSG. We compared the level of the 3 cytokine with the frequency of each symptom contained in the 2 questionnaires. Yeah. There were 82 subjects who met the inclusion criteria. 2 subjects declined to participate in the study, while 15 were excluded because the endoscopic examination revealed other pathologies with the following characteristics: 10 subjects with erosive gastritis, 1 subject with gastric polyp, and 4 subjects with gastric ulcer. And in this study, it include 65 participants in total. The study sample primarily consisted of women with an average age of approximately 40 years and a body mass index of approximately 24. The study population demonstrated a diverse distribution of ethnicity, with the Javanese being the most dominant, followed by the Madurs and Mongoloid and Sundanese. The endoscopic result revealed that up to 30% of the subjects saw erosive damage, specifically classified as LA grade B and grade C. No subject exhibit LA grade D or Barrett esophagus, and approximately 70% of the subject exhibit normal endoscopy result of classified as LA grade A. The predominant finding of esophageal biopsy were normal histology, chronic esophagitis, and glycogenic acanthosis. The median value of the total score from 2 questionnaires and the 3 cytokine as follows. Okay. After comparing the level of these 3 cytokine in both groups, we discovered that only serum IL-8 increased statistically significantly. The erosive group has higher level of IL-8 than the non-erosive group. And when performing sub-analysis for each degree of mucosal erosion based solely on the Los Angeles classification, we also obtained comparable outcome. But in contrast, TNF-alpha and IL-17 did not exhibit a similar association. On the other hand, we found no correlation the level of the three cytokine with histopathology of esophageal biopsy. I'm sorry. After comparing the level of these 3 cytokine in the both group, we discovered that only serum IL-8 increased statistically significantly. The erosive group had higher level of IL-8 than the non-erosive group. And when performing sub-analysis for each degree of mucosal erosion, based solely on the IL-8 classification, we also obtained comparable outcome. Okay. The analysis of the relationship between these 3 cytokines and the total GERD-Q and FSSG score failed to reveal any statistically significant differences. Interestingly, when we performed sub-analysis, we discovered that these 3 cytokines were associated with distinct GERD symptoms. Higher level of TNF-alpha are associated with regurgitation symptom, while higher level of IL-17 are associated with heartburn symptom. And IL-17 also associated with the presence or absence of early satiety symptom, whereas IL-8 was associated with globus symptom. And our study finding aligned with the several prior research. In our study, among subjects we presenting with typical GERD symptom, those with erosive esophagitis have substantially higher serum level of IL-8 than those who do not. And in the literature, we find of the increase of IL-8 serum is associated with erosive esophagitis, refractory GERD, and recurrent mucosal erosion. An in vitro study demonstrated that acid exposure did not induce direct cellular death. This condition turned out to induce the secretion of IL-8 by epithelial cell, leading to the infiltration of inflammatory cell into the nearby tissue. And our findings suggest that IL-8 may have a significant role in the development of mucosal inflammation in GERD. Elevated serum level may be indicated excessive production of IL-8 by the esophageal epithelium, which can be used to determine the presence of mucosal erosion. Okay. This study also observed a significant correlation between these 3 cytokines and various symptom perception. The newly discovered phenomenon has not been previously. This is a newly discovered phenomenon has not been previously documented, and heartburn and regurgitation are the 2 most typical symptoms of GERD, but their underlying mechanism differs significantly. Our findings suggest that IL-17 activates and sensitizes acid-sensitive receptor on afferent nerve and in esophageal squamous epithelial tissue and causing heartburn. And IL-17 can trigger apoptosis of M2 macrophage, causing damage of causal interstitial cell, and this damage ultimately lead to gastroparesis, which manifests as the symptom of early satiety. TNF-alpha play a role in the development of transient relaxation of the upper and lower esophageal sphincter, reduce peristaltic amplitude, and increase reflux symptom, which manifests as the symptom of heartburn. And IL-8 is involved in the both activation of the vagus reflex and the injury of the laryngeal mucosa resulting from the recurrent proximal acid reflux, and this which manifests as the symptom of globus. Okay, this study yield two primary conclusions. The first is IL-8 play an important role in the development of mucosal irritation in gut, and the second, the different symptom phenotypes observed in the patient with gut are mediated by distinct profile of pro-inflammatory cytokine. Okay, thank you.
Thank you very much for your presentation. It's open the floor for any questions.
So maybe I got a first questions. All of the IL-17s, IL-8, and TNF-alpha is a pro-inflammatory cytokines, right? And I believe that you can explain why this pro-inflammatory cytokine is going to be more in the patients with heartburn. But how you can explain the come-ups of these cytokines that induce the inflammation with correlation with the symptom of regurgitation?
I think we want to conduct the future research to assess how is the cytokine well associated with the specific symptom in symptom perception, and maybe in the future maybe we can give anti-interleukin or anti-TNF-alpha for the symptom if they dominant. Thank you.
Okay, do you have any more? If no more questions, before we end the sessions, I'd like to invite Professor An to give a certificate to Professor Ting Tan for a great memory. And before we close session, I'd like to invite Professor Pinit, Professor Yamalgap, and Professor Mahashai to come up at the floor to take pictures with the new face of the gastroenterology in Asia. And I'd like to invite all the rising gastroenterologists to come up to the in the Asias, come up to the floor, please. I believe that we're going to know the power of the new face of the gastroenterologists, and believe that all of them is going to have a new chapter for the next treatment and the new knowledge that provides for our society. And I'd like to end the Rising Gastroenterology sessions. Thank you so much for attending this session.